learning a little bit more about incontinence as well as pelvic organ prolapse, which often can accompany that. A little bit about myself. I am originally a Floridian, relocated out here to the desert with my wife and my family. We are part of the Eisenhower family and we're absolutely loving it. We're both board certified gynecologists. We are practicing hopefully in our new Bannon office here very shortly. For the time being, we are on Rancho Mirage in the Hewitt building. So if you do have any questions or concerns or would like to meet with any of us after this, feel free to call Eisenhower and set up an appointment to talk with us about this. So I'm going to go ahead and get started. So like the title says, so I'm just getting rid of that pop-up. Today we're going to talk a little bit about some conservative prevention strategies, as well as some ways that we treat female incontinence, as well as pelvic organ prolapse. And I chose this topic because I noticed very quickly after training that incontinence was something that just wasn't addressed enough. I met a lot of patients who routinely were wearing incontinence pads, and their quality of life was dramatically affected due to the symptoms of incontinence. And pelvic organ prolapse is on the same wavelength. A lot of women are affected by this, and unfortunately, I don't think we do a good enough job about informing patients about their options and ways that we can help you have a better quality of life, because that's what it comes down to at the end of the day. So what is incontinence? So incontinence is the loss of urine. So we're talking specifically about urinary incontinence, okay? So loss of urine that is not voluntary, so involuntary loss of urine. It can be common in young women, especially younger women after childbirth, but we find it to be significantly common in women over the age of 60, and particularly about 70% of women. There are several different types of incontinence. There is stress incontinence, there is urgency incontinence, there is mixed incontinence, and there is overflow incontinence. Today, we're going to talk mostly about stress and urgency, but we'll touch briefly about mixed and overflow. Symptoms a little bit about incontinence. Patients may report, I have the urgency to run to the bathroom and I don't make it to the bathroom. Or I'm playing with my grandkids and every time I pick up that little one, I seem to lose a little bit of urine. Or I'm out there playing 18 holes of golf and I can't finish the game without losing some urine. Maybe I wake up in the middle of the night and I have accidents that I didn't mean to. So we're going to go a little bit more about the symptoms of incontinence in a little bit. So one of the questions I ask women when they come into me to kind of gauge how bad the incontinence might be is, are they practicing something called toilet mapping? And toilet mapping is when you go to either a facility, a mall, a shopping bonanza, maybe an art show, or you're out there playing golf, is the first thing you think about, where is the nearest toilet and where is the second one in line? Now, if you're doing something like that, you're practicing something called toilet mapping. Toilet mapping is something that you shouldn't have to do. Now, timed voiding is a different concept where you're actually engaging in voiding throughout a specific time interval. But toilet mapping is you're a little afraid you're not going to make it to the bathroom, so you need to know where your next spot's going to be. Okay. So our risk factors associated with incontinence. Risk factors: age, like we said before, younger women can experience incontinence, but it's really, really, really common as we get a little older in life. Unfortunately, females tend to experience it more than males. Obesity is a significant factor that is associated with incontinence, as well as parity. And what parity means is how many children have you had? Specifically, vaginal deliveries. So vaginal deliveries are associated with much more incontinence episodes than cesarean deliveries, but that's not to say that somebody who's had a cesarean delivery can't experience incontinence. In fact, I have plenty of women out there who they've never had children before and they have incontinence. It's possible. And we know that ethnicity actually is a risk factor, and that white individuals tend to have incontinence more so. And there's a subset of patients that have medical conditions that might be attributing to their incontinence. Specifically, diabetes can affect people's incontinence issues. People who've had damage to their spinal cord, these can affect the way that those neurons are stimulating their bladder and unfortunately result in incontinent episodes. So stress incontinence. Stress incontinence is one of the more common types of incontinence that I run into. There's two different types of stress incontinence. There is urethral hypermobility, as well as ISD, or intrinsic sphincter deficiency. So urethral hypermobility is the more common of the two, and essentially it's a insufficient support of your pelvic musculature and the vaginal tissue. It causes the urethra and the bladder neck to lose the ability to completely close against the vaginal wall, and this results in any sort of event allowing urine to slip out and cause an incontinent episode. Now, intrinsic sphincter deficiency is the loss of the intrinsic sphincter, mucosal, and muscular tone, okay? And this is less common than urethral hypomobility, a little more difficult and challenging to manage as well. That's not to say we don't have options, because we have plenty of options out there for you. Now, when we talk about stress urinary incontinence, the couple questions I ask patients are you losing urine when you're coughing? Now, smokers, they tend to cough a little bit. So I do notice that when we cough and when I'm examining them and they cough, you will experience a little bit of urine leakage. We call that a cough stress test. And that's part of the actual examination process that I perform on patients. Now, are you losing urine with laughing, sneezing, working out, or even sexual activity? If so, you may be experiencing some symptoms consistent with stress urinary incontinence. Another type of incontinence is urge incontinence. So urge incontinence, it's also used very interchangeably with overactive bladder, okay? The incontinent part is where the difference is made. So this is an urgency followed by a loss of urine. And as we discussed earlier, these are all involuntary losses. The volume is variable. It can be on the level of small droplets. It can be on the level of large volumes that soak through not only your sanitary pads, but your clothes. And like I previously stated, very interchangeably used with overactive bladder. The other terminology utilized by medical professionals is detrusor overactivity, or your bladder being a little overactive, or having a little too many spasms per se. And like we said, there is an increased incidence with older women, unfortunately. So the other two types, which are a little more complex in nature, are mixed incontinence. And mixed is essentially a little bit of stress, a little bit of urgency. It's a combination of the two. And then you have overflow incontinence. Now, overflow incontinence can be a continuous leakage or dribbling with some incomplete emptying associated. Detrusor underactivity is one of those types of overflow, and it's associated with medical conditions. Like we previously discussed, we might have somebody who has spinal cord injuries. We might have medical comorbidities such as diabetes that are contributing. Maybe there is a genetic basis with some abnormal defects in our structural proteins that are affiliated with this. And then there is bladder outlet obstruction. And these are patients that I do tend to see from time to time, and they might come in and they say they have incomplete emptying, and we do some ultrasound and some testing, and we notice they have fibroids, or maybe they have a little bit of prolapse. And these are two items that can unfortunately lead to you not being able to evacuate all the urine out of the bladder. So next, we're going to talk about our evaluation. So number one, if you're having incontinence and it's affecting your quality of life, I'd say the number one thing to do is to bring this up to your provider, whether it's a primary care physician who's able to refer you to the right individual, or your gynecologist or your urologist. We're all able to get you to the right person who's able to help you out, okay? So there is a 3IQ questionnaire. This is a questionnaire we utilize quite frequently, and this is a questionnaire that's filled out by patients. It can be filled out in the waiting room, and this helps us ask some questions that might help us determine and ask some leading questions to help us determine what type of incontinence and tease that out. So as you might notice here, I've actually placed the questionnaire here on, I believe it would be your right side. And it gives the answers, and it allows us to have an idea about what incontinence we might be dealing with. So there's also voiding diaries. I utilize these quite frequently when patients have incontinence. This helps me analyze what people's habits are at home. I review their medications. It's commonly known that a lot of medications can be affiliated with incontinence. Antihistamines are one of them. Opioids, which are also known as pain medications, benzodiazepines. So these are medications sometimes we use for anxiety. There's also a significant association with blood pressure meds, especially diuretics. And a lot of my patients tend to be on diuretics, and this causes them to have to make larger volumes of urine, and they have to void more frequently. And lastly, some antidepressants are rarely but can be associated with incontinence. After reviewing their medications, I want to make sure that there isn't any underlying urinary tract infection. Now, urinary tract infections can result in incontinence. Sometimes these patients also complain of frequency in urination. They say they have some pain with urination. There might be a foul smell. And if we do think there's a UTI, we want to test for this and treat accordingly. Anytime I'm evaluating a patient for incontinence, I'm always checking for a urinary tract infection because quite frequently there is an underlying urinary tract infection. Another question you need to ask the patients are, how much is this altering your life? If this is to the point where you're wearing sanitary pads and you're utilize them every day and you're not able to enjoy the activities that you're accustomed to, this is the time when you need to start bringing this up to your practitioner. Let us help you, okay? And lastly, a physical exam. A physical exam is very important. It can help us determine what types of incontinence or what attributable factors might be there related to either your body habitus, maybe there's some prolapse there, maybe there's any sort of fibroids that might be contributing, and also whether or not you have a positive cough stress test, which might be indicative of stress urinary incontinence. So I've put up a voiding diary here to the right. These are underutilized by a lot of professionals out there, but I think they're extraordinarily helpful. These are a way I kind of am able to peer into patients' habits, determine how much are they urinating on a level of the volumes. What else are they putting into their bodies besides those medications they tell me about? Are they drinking a significant amount of coffee? Are their alcohol habits maybe in excess? Now, coffee and alcohol can be bladder irritants. They can unfortunately cause symptoms of overactive bladder or bladder irritants per se. And often decreasing the amounts or even omitting those from your diet can be awfully helpful. And then lastly, you'll see that big water jug up there. And that's to determine how much water you're taking into your body. If you're taking in excessive amounts of water, well, you're going to expect it to probably have a significant amount of voiding episodes every day. So this kind of allows me to analyze behaviors outside of the office and kind of determine whether or not we need to make some lifestyle adjustments per se. So stress incontinence. Let's talk about some preventative strategies. So I know it's nothing anybody wants to talk about, but unfortunately, obesity is associated with stress urinary incontinence, and weight loss can be really helpful at decreasing those incontinent episodes. Like I said, dietary modifications can be extraordinarily helpful, decreasing the amount of your bladder irritants that you're taking to your body, such as alcohol, such as coffee. Those can be extraordinarily helpful. Smoking cessation is on the top of the list. Smoking cessation should be on the top of the list with a significant amount of medical comorbidities, not just incontinence, but overall just a lifestyle modification you should be omitting entirely. Constipation, anything that's increasing your abdominal pressure, that coughing, laughing, sneezing, having to give a little bit more effort to evacuate your bowels, these can all contribute to stress urinary incontinence. So treating constipation, making sure that flow is normal and you're not constipated, these can decrease those episodes you might be experiencing. So you might notice I have a big stoplight up here, and you're wondering yourself, what does a stoplight have to do with incontinence? Well, when I talk to patients, one of my things I like to ask is, how often do you do your Kegel exercises? And I would say a majority of my patients say, oh, I stopped shortly after my children, or my doc did talk about it, but I forget to do it all the time. So one strategy I employ is I tell patients, every day you get into your car, right? And for most of us, the answer is yes. And when you get into your car, you probably hit a red light, right? Well, for most of us, it is yes. And when you hit that red light, you sit there for a couple seconds, right? Well, yeah, of course. So that red light is an opportunity. that's an opportunity to practice your Kegels. And you can find yourself getting in several Kegels in a short little trip over to Ralph's. So my recommendation is 8 to 12 Kegels 3 times a day. And Kegels are extraordinarily important. Just like working out to go and run a marathon, these Kegels are going to strengthen your pelvic floor and hopefully be a preventative strategy to encounter things like incontinence in the future. They can also be very preventative to strengthen your pelvic floor to prevent things like prolapse that you might experience in the future. Now, outside of some of these very conservative measures, we do have some other modalities out there. So like I said, timed voiding and emptying your bladder at routine intervals can be very helpful on decreasing these episodes and decreasing the volume that's accumulated in the bladder. Pelvic floor therapy is extraordinarily helpful. And here at Eisenhower, we have a wonderful program. I feel as though pelvic floor rehabilitation is very underutilized. I do talk about pelvic floor rehab a lot with my prolapse patients as well as so as I said, we have a great pelvic floor rehabilitation program here. People are a little cautious about going to pelvic floor rehab because it's a very intimate organ. But trust me when I say the benefits are extraordinary from them. So bladder training, this goes hand in hand with time voiding. This is, making sure that volume inside the bladder is decreased as much as possible and doing this at shorter intervals. I.e., that doesn't mean that I want you to be using the bathroom every hour. If that's the case, then we need to look at alternative management options. Topical vaginal estrogen can be very helpful as well. Unfortunately, when we go through menopause, there is this drop in estrogen that happens. And with a drop of estrogen, there's a lot of changes that women go through. They have changes in their skin, hot flashes, night sweats, vaginal dryness. And that vaginal dryness is unfortunate. It's experienced by a lot of women and it's undertreated. Treating that vaginal dryness might also help treat with some of these incontinent episodes. It's not for everyone, but it can offer a significant improvement for a lot of women. And then lastly is surgery. Now, surgical techniques are many. In particular, there are something called bladder slings that people utilize, specifically myself. There's a couple different approaches to placing these. These are one of my favorite procedures to do for women because the satisfaction from them is unbelievable. You're able to offer a quality of life where patients are able to resume their normal activities at a very short interval. And it's a very minimally invasive surgery. So surgery is an option, albeit it shouldn't be for everyone. It's not the first option, but it is an option. So overactive bladder and leading to urge incontinence in our treatment. So like we talked about before, Kegel exercises. Kegel exercises are so important. They're not just important for incontinence, but they're important for pelvic health altogether. Adjustment of medications, in particularly, maybe changing up some of the blood pressure medications from diuretics to alternative modalities could be helpful. This is something you should be talking to your primary care and consulting with them in regards to this. Dietary modifications, staying away from those bladder irritants we talked about, decreasing your alcohol intake, as well as your coffee or caffeine intake. Lifestyle adjustments can also be helpful. There are medication alternatives. There are oral medications, which I utilize quite frequently. And then I have my friends at urology who are able to offer a significant amount of alternatives in regards to percutaneous tibial nerve stimulation, possibly Botox. These are all possibilities that can be offered by a urologist. So let's move along to pelvic organ prolapse. So this is my lovely uterus here. This is something that I feel needs more and more attention. I can't tell you how many times I see patients and I say, how long have you been dealing with this for? Oh, there's something I can do about that? Absolutely. So what is prolapse? So pelvic organ prolapse is essentially a weakness in the structural integrity of pelvic support. Now, unfortunately, identifying the actual incidence and how many patients deal with this is very difficult because it's very underreported. So step one, talk to your doctor. And what kind of symptoms might you be experiencing is probably your next question. So if you're feeling a bulge in the vagina, are you feeling something that is coming out of the vagina? Are you feeling pelvic pressure? Do you have lower back pain when standing for long periods of time? Is there any associated urinary dysfunction? Any defecatory dysfunction, such as constipation? Any sexual dysfunction? Okay, is there any pain with intercourse? Now, the types of pelvic organ prolapse. We'll start off with our normal anatomy. You'll notice the bladder is there in the front, the uterus is there in the middle, and the rectum is behind it. The first term you'll see there is cystocele, and cystocele is essentially what we call a bladder drop in layman's terms, okay? So it's very common to see in a lot of women. Some women are not very symptomatic from it, but some women are very symptomatic from it. And then there's something called uterine prolapse, and you'll notice that the uterus has altered where it initially was located in your normal anatomy, and it's further down within the vagina. And then there's something called rectocele. Now, rectocele is when the rectum actually outpouches into the vagina. So we're talking about 3 different types of pelvic organ prolapse. Now, does that mean you can only have one? Absolutely not. I have patients who have all 3 of them. I have patients that just have an isolated rectocele. I have patients who have had a hysterectomy, and they say, Doc, I don't have any organs anymore. What could be prolapsing? Well, believe it or not, that end of that vaginal cuff, if it's not suspended properly or age has taken effect, these things can drop into the pelvis and start to cause you some of the symptoms we previously discussed. So the risk factors for prolapse: increased incidence with increasing parity. So like we talked about before, parity means how many children have been birthed by the patient. Vaginal births more so than cesareans, but not always. The weight of the infant. So women that are having larger children are going to be more prone to having prolapse. Age. So as we get older, things become a little looser. Our skin becomes a little looser. Well, the same thing happens to our pelvic organs. They become a little bit looser. Those ligaments that hold those organs up inside, nice and high inside the abdomen, they become a little bit lax. And they allow things to drop into the vagina. And like we previously discussed about incontinence, obesity. That's why I say obesity is just so important. If we can start to have some weight loss earlier in life, maybe we can prevent some of these things before they ever happen. Chronic cough and constipation. And similarly to incontinence, and particularly stress incontinence, anytime you increase that abdominal pressure with that cough, with that having to urge and push to evacuate the bowels, we might actually be contributing to developing some pelvic organ prolapse. And connective tissue disorders, these are unfortunately associated with an increased incidence of pelvic organ prolapse and a family history. So your mother who had prolapse, she might have had very small children, and she might have a very significant history of prolapse, and you, unfortunately, might be subject to experiencing prolapse as well. So when I'm dealing with prolapse, I'm examining the patient, and I might identify something that she might have never noted there before. And I ask, how bothersome is your prolapse? Is it affecting your quality of life? Did you know it was there? Let's talk about some of the symptoms. Are these some symptoms that maybe you haven't talked about, that you have been experiencing, that you've just suppressed and just lived life? Is your quality of life affected? Do you find you're not able to partake in normal activities? I have plenty of patients, and they're active. They're out there playing tennis with their girlfriends, playing 18 holes of golf, but they have to stop halfway through to push everything back inside. That's not something you should have to deal with. Like we just discussed, are there any limitations with your daily activities? Are you unable to exercise due to prolapse? So anytime you're increasing that abdominal pressure, you're working out, you might experience some prolapse. In very severe cases, it might alter your workouts. You have to stop and push things back inside. And lastly, has your sex life been altered due to prolapse? This is unfortunate, but it's quite common. Some women come in and they say, I'm having pain with intercourse. Nothing's changed. My partner's been the same gentleman for the past 60 years. What is going on, doc? And unfortunately, a lot of this has to do with prolapse. So we have management options. And like I said before, pelvic floor rehabilitation is extraordinarily beneficial. Expectant management is one alternative. A lot of time, these are the patients I see and I say, hey, we've got something going on here. Did you know about it? Just, no. Well, did you have any symptoms related? No, I don't. Well, in those particular situations, I say, you know what? Let's watch things. Let's be a little bit better about, lifestyle changes. Let's practice regular Kegels, and let's see how things go. If we start to be symptomatic, then maybe we want to start to do something about it. So our conservative management options are that PTOT stands for physical and occupational therapy, and that's that pelvic floor rehab we talked about. And then we have things like pessaries, and pessaries are very underutilized, but I find them to be such an important tool that we have for a lot of women. And then topical hormone replacement. This can help with very early prolapse, but it doesn't exactly fix prolapse, okay? And then we have surgical options out there. Now, when it comes to surgical options, we have a slew of management alternatives. Anything from the utilization of mesh to not utilizing mesh and using your normal tissue to using grafts. There is a multitude of different procedures. And this is really a discussion that could go on for hours as far as the options that can be offered to a patient. But really, that's something that is tailored to each patient. And you can't say every patient gets the same thing. It's got to be the right decision for the right patient. So next, I put a slide up of pessaries. Okay, like I said, pessaries are very underutilized. My favorite pessary is not on here. It is a ring with support, but I find it is extraordinarily helpful to patients. These are not only helpful for patients who have prolapse, but they can be very helpful for patients who have prolapse, especially with concurrent incontinence. So we're going to be wrapping up. This, is a slide about how that pessary sits inside. So people often ask, well, I'm going to put a pessary in. Can I have sex with it? Do I have to take it out every night? And the answer is no, you don't have to take it out every night. And yes, you can have sex with it. It sits high up into the vagina, and it essentially keeps things suspended so they don't fall out. Now they do need to be removed and they need to be cleaned. There is an initial period where we like to inspect the vagina to make sure it's the right fit for you and it's not causing any problems. But like I said, these can be a very, very, very valuable tool to a lot of us. So pelvic organ prolapse prevention is do your Kegels. I know it doesn't sound like something you want to hear, but at every stoplight, I want you to think and take a second and Kegel a couple times. And at the end of the day, you'll notice you've been able to fit in quite a few Kegels and you're strengthening or working out your pelvis. So appointments, please contact us here at Eisenhower Health. We'd be happy to assist you in any of your gynecological problems, specifically prolapse and incontinence. We'll be having several more webinars in the future in regards to women's health. Like I said, I feel like women's health here in the Valley needs more attention brought to it. So expect to hear more from me out there. And thank you very much. I appreciate all your time.